You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Stephen R. Feldman, Professor of Dermatology, Pathology, and Social Sciences and Health Policy at Wake Forest University School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Welcome to Medscape In Discussion Psoriasis. I'm your host, Dr. Steve Feldman. In this fourth episode of our second season, we'll focus on oral psoriasis treatments. Who benefits most from taking oral agents? What are the advantages and disadvantages, if any? Our guest is the current president of the Society of Dermatology Nurse Practitioners and a member of the National Psoriasis Foundation's Emeritus Medical Advisory Board. She's a practicing dermatology nurse practitioner who has published and co-authored articles on the management of patients with psoriatic disease. Welcome, Lakshi Aldredge.
Thank you, Dr. Feldman. I'm delighted to be here.
Lakshi, how did you decide to focus on dermatology as a specialty?
So I've worked at the Portland VA here in Portland, Oregon for the past 32 years. And when I started in dermatology, I was fortunate to work with many residents and with one of my mentors, Dr. Andrew Blauvelt, who has a passion for caring for psoriasis patients. So under his tutelage, I really fell in love with psoriatic disease and these patients who really suffer from this horrible disease. And so from that point forward, I sort of decided that that would be my path. And so I've really enjoyed for the past 22 years caring for patients with psoriasis, psoriatic arthritis, and enjoying the evolution of treatment options that we have had for them.
What a great way to start. Dr. Blauvelt, Andy, if I wanted to know something about psoriasis, he'd be somebody I'd go to.
I was very fortunate, yes.
Yeah, and you've been doing this for 20-something years.
Yes, I have, not to age myself, but back in the day, we were just beginning to introduce the biologic therapies. And so we've come such a long way, and I'm really excited to talk with you more about some of our newer treatment options.
You're a nurse practitioner. You have so much experience managing patients with psoriasis. I assume you're at least as good as I am at it. What generally is the role of a nurse practitioner in managing patients with psoriasis or other conditions?
That's a really great question, Dr. Feldman, and a question that I get often. What is the role of nurse practitioners and even physician assistants in the derm clinic managing psoriasis? And really, we are part of the dermatology care team. There are many different settings where psoriasis patients are seen and treated. It may be in a private practice clinic, it may be in a university setting, or it may be in a public health clinic. So in all of these settings, there's a wide variety of what we call a derm team. That may include a physician-led team, it may include a nurse practitioner or a physician assistant, but I really embrace and endorse this concept that the most successful management of really any dermatology patient, especially those with complex chronic cutaneous disorders, are really best managed by a derm team. So for me, working in an environment where, as I have become comfortable under the guidance of a collaborating physician and another expert in psoriasis, really gained confidence, he allowed me to practice independently as I gained confidence and felt comfortable caring for patients, and he was able to see my management technique. But as I said, it's been a 20-year journey. So I feel every nurse practitioner and physician assistant is different. We definitely have a need in the field of dermatology to have providers seeing patients. We know there's a great access issue. So I really believe in the management of psoriasis, a team-based approach benefits the patient the best, and I feel that nurse practitioners are an important and integral part of that team, and certainly with the right teaching, the right understanding, the right confidence, they can comfortably care for patients once they gain that education.
I imagine that the rules vary from state to state, but that maybe some states allow nurse practitioners to basically practice independently and even in situations where physician extenders are part of the team, it seems like a lot of the time they are practicing for all practical purposes, nearly, if not completely independently for many patients. And that doesn't bother me because in my experience, the physician extenders I've worked with have been fabulous professionals. What's your sense about the concern some physicians have with the independence of nurse practitioners?
And it's been on the forefront of the American Medical Association, certainly the AAD, is this concept of non-physicians caring for patients, setting up independent practices. And in almost all states now, nurse practitioners can practice independently based on their scope of training, education, and competencies. In the state of Oregon, we have practiced independently for many years. In fact, we were one of the first states. And really, what's important to understand is the role of nurse practitioners evolved from the military as a need for care expanded to rural communities where patients had a difficult time getting into medical clinics or coming into the city. So it was really born out of a need for patients to get medical care. That being said, it is few and far between nurse practitioners that practice independently in the United States. The majority of those nurse practitioners have gained their education and training in formal training programs. We have 3 dermatology nurse practitioner fellowship training programs that are year-long. They have also studied as nurses for 4 years, and then as nurse practitioners, our education is an additional 3 to 4 years, so that's 8 years, plus then an additional year of training within the dermatology specialty. So there is a rich amount of education behind dermatology nurse practitioners. But I really feel, again, that the majority of nurse practitioners are practicing within a collaborative practice under a team model. What is important to understand is with chronic conditions such as psoriasis, atopic dermatitis, in the United States today, the majority of those patients are being cared for by nurse practitioners and physician assistants, whether that's practicing independently, but by far the majority are within a collaborative practice with a setting with physicians, nurses, Mohs surgeons, other nurse practitioners and physician assistants as well. And I think that that's a model that works really well. But I know in communities of need, rural areas, hard to recruit dermatologists to those areas, nurse practitioners have really filled an important and integral need.
Excellent. All right, let's move on to the topic of the day, which is the use of oral agents. Which patients are eligible with psoriasis for oral treatment?
I think that this is a critical question. And I think it was Dr. Kruger who taught me that, we moved away from treating patients according to their severity, right? Traditionally, we had the mild, moderate, and severe patient. And then, we treat mild patients with localized disease with topicals. And then if they had moderate, you would consider oral agents. And then if they had more severe disease, we would move right to the biologics. And that paradigm has shifted. And it really is more looking at the patient sitting in front of you, whether they are a candidate for if they have localized disease and topicals are appropriate, or if they really need to move to the realm of systemic treatment of their condition, regardless of the body surface area that is involved. So then when we look at systemic management of psoriasis, we have oral agents, and then we have the biologic therapies. And then within that oral spectrum, we have the traditional oral agents, methotrexate, cyclosporin, acitretin. And now we have some new additions to that armamentarium, the TYK2 inhibitor that has come down, and the PDE4 that's been around for a while that really does increase that palette that we can draw from. So when I'm looking at the patient sitting in front of me and they are a candidate for systemic therapy, thinking about the oral agents, there's a couple of considerations. First of all, what are the patient's comorbidities that may affect my selection choice? And unfortunately, in this day and age, we also have to think about their financial situation. Do they have insurance coverage? If not, that may take certain medications off the table for me. And I will tell you, especially working within the VA system, Methotrexate has been a go-to for a very long time. It works well, and it's a great starting point for a lot of patients. But really, I believe in very individualized therapy. So before, when we would have an algorithm, you would start a patient on topical therapy, perhaps phototherapy, and then go to methotrexate. Those are step therapies that have sort of gone by the wayside. So I believe that the patient sitting in front of you, they have very specific needs. They're also very sophisticated now, thanks to direct-to-consumer advertising about what their knowledge is of therapies that are available and what they want that will fit in with their lifestyle.
It seems like lumping these things together as oral agents has certain limitations since methotrexate is so different from, say, a Premolast. What are some of the things you think about when you're starting these oral agents? And you can be specific for each one if you like.
Absolutely. So, cyclosporin has been around forever. In fact, it's one of the first ways that we identified that psoriasis was actually an immune-mediated disease. So cyclosporin, of course, we use as a rescue agent for severe patients who may be experiencing a significant flare or who may be transitioning to another systemic therapy, such as a biologic. When I think about methotrexate, this is an agent that I sometimes use for my underinsured individuals. But the consideration with methotrexate, especially if it's a young male or female, you're thinking about family planning, if they're thinking about becoming pregnant, that is an important consideration with both methotrexate and acitretin. Also thinking about their other comorbidities. Do they have a history of liver disease? Do they have metabolic syndrome? Are they more obese? Do they have kidney issues? So methotrexate, a lot of patients really may not qualify for that. Another big consideration is if they use alcohol on a significant basis.
Let me just ask you something else about methotrexate, because it sounds like we're heavily focused on patients' livers when we're talking about methotrexate, because you mentioned their alcohol use. And it just made me wonder, is there a role for liver biopsy anymore in those methotrexate patients?
No, that really has gone by the wayside. So oftentimes, if a patient has reached, 2 or 3 grams, I might send a consult for a fibroscan, which has really become one of the typical imaging studies that we use to assess liver disease. I might send them for that. But I really don't have patients on methotrexate that long. And when I've consulted my liver colleagues, if liver's functions are doing well, patient is stable, they really don't feel a need to do any further imaging. And certainly they haven't done biopsies for years now.
Excellent. And you mentioned cost. When I really wanted to help somebody in terms of low cost, I would prescribe the liquid methotrexate, which was even less expensive than the pills. But now I feel like, I haven't done that in so long, because the support from companies to get people biologics has been so good. It's almost easier to get a patient a biologic than it is to make them pay for methotrexate sometimes.
And you do have to do liver enzymes. I do a CBC, some baseline testing, and then when they first start therapy, I may bring them back in 6 weeks to recheck their liver, and then certainly every 3 months for some time before I feel comfortable that they're stable. And unfortunately, these lab tests cost, and sometimes patients have to pay out of pocket for that. So that definitely is a consideration.
Okay. The next drug I think I heard you talking about was acitretin.
Yeah, acitretin has been around a long time, but both with methotrexate and acitretin, these are drugs that take a long time to see efficacy. We ramp patients up with that, and they can have significant side effects. I have the best luck with acitretin for my palmoplantar psoriasis patients along with UVB therapy. It's not highly efficacious for widespread plaque disease. The side effects that I worry about are dry skin, dry eyes, so tolerability for patients. And again, you do have to think about checking triglycerides and lipids along with liver. So it can be a little bit more cumbersome, but for some patients, it's a great option. I've had patients who have been on it for years. It has worked well for them. So definitely still on my menu as I introduce options of oral therapies for patients.
Except for women of childbearing potential.
Correct. Along with methotrexate, that is a big concern.
Yeah. I have trainees who weren't familiar with acitretin, and I can make them real comfortable with it really quickly just by telling them, well, you prescribe isotretinoin to acne patients all the time. The side effect profile is almost identical. The laboratory monitoring is basically the same. If you could do one, you certainly do the other.
Absolutely.
And then we have some newer oral agents.
Yes. So our PDE4 inhibitor, apremilast, has been around for some years now, and it really changed our menu as far as oral therapies. When that was introduced to us, it gave us an option of a very novel mechanism of action, and it was incredibly safe. No lab monitoring required. Didn't seem to have any pregnancy contraindications for our younger patients. The only issue with apremilast, of course, is the potential side effects of GI upset, diarrhea, cramping, nausea, vomiting. So when you start this medication, they actually ramp up. It is twice a day dosing, which can be cumbersome to some patients, especially our younger folks living their very busy lives, but it is highly efficacious as far as the oral agents that we were using, and a great option for patients, especially those who had some of those comorbidities I mentioned. Really, the only consideration with apremilast is the fact that if you had a patient who had renal compromise, you may think about going from twice a day dosing to once a day dosing. But really well tolerated for the most part for most patients. The GI symptoms seem to improve over time, so it could become very well tolerated for some patients. In some patients, this was highly efficacious, with patients reaching clear or near clear disease. But for the most part, what I continue to see is it seems to be tolerated for a while, and then patients come to me and saying, hey, what's new? I feel like I could get a little bit better clearance. I still don't want to be on a biologic, but are there any other new oral therapies? It really has been a godsend. Also, for my patients who may have some other significant comorbidities. They may be going through cancer therapy. They may be going through surgery. They have a lot of other diseases where they're taking a lot of medications and they don't want to be on a biologic. Apremilast is a safe choice that's quite convenient.
I get the sense you hit home runs with oral apremilast maybe 1 in 10 times. I think most patients have some improvement. I don't think of it as being highly efficacious like some of the biologic options I have. One of the side effects can be weight loss. And, most patients, if I tell them, unfortunately, one of the side effects is weight loss, they're like, oh, that's great. I'd love to lose some weight. Have you seen any patients who had excessive weight loss to the point where you considered it an adverse event?
No, I really have not seen that. But I will tell you, in my elderly patients where I would worry about them losing more weight, it may not be my first option. But I really, in all of my prescriptions, have never taken a patient off of apremilast because of significant weight loss. Have you found that to be the case?
Just once. I would have sworn she had cancer from the severity of her weight loss. And then I realized, wait a minute, you're on apremilast. Let's take you off, and her weight right back up. Okay, well, we have one even newer agent, deucravacitinib. How are you using it?
That's really, really exciting. When it first came on the scene, we were talking about the concept of a JAK inhibitor in the dermatology space was sort of terrifying to everybody, I think. We had learned from our rheumatology colleagues that while this is an efficacious drug in the room setting, it did come with this sort of baggage of really scary side effects. And so when we were thinking about how is this going to work with our psoriasis patients who, with psoriasis, we definitely know that more severe patients are more likely to develop some comorbidities. Here now we're going to give them a drug that could potentially cause other things. We were really worried about this. So what we have been pleasantly surprised about is the safety profile of this drug. Highly efficacious, probably along the lines of a TNF-alpha inhibitor, biologic therapy, long-term efficacy, but more importantly, a really nice safety profile. So those worrisome side effects that we saw with JAK inhibition in our rheumatology patients, we are just not seeing that in our dermatology patients. Now, mind you, TYK2, as you know, is a very specified JAK inhibitor with TYK2 inhibition looking very different than the other JAK products that we've seen. Nice efficacy, long-term efficacy, and a really nice safety profile. Seems to be well tolerated by patients. Once a day dosing, which is nice and convenient. However, I think providers really are going to have a hard time, if they haven't prescribed this yet, having the conversation with their patients about the potential side effects. There's no black box warning with this drug. There are recommended lab monitorings that initially should be done, which is also the case with biologics, but really a wonderful option as far as a non-PDEF, a change from methotrexate and acitretin with efficacy within a relatively short period of time, I would say, and PASI 75 numbers equivalent to a biologic.
Yeah, I think there's maybe a signal for herpes virus infection. Are you getting people up to date on a shingles vaccination before starting this drug?
We really recommend that for all patients. Haven't seen it, haven't heard about any significant cases of this, but I do think that it is important, and I have this conversation with all of my patients before starting any systemic therapy, really making sure that they're up to date on all of their immunizations.
Well, let's summarize what we've discussed today. Psoriasis management is a team sport, and physician extenders are playing a large and growing role in the management of patients with psoriasis. When we see patients with psoriasis, we could think of it as two diseases: a mild form where patients can get by with just topical therapy, and more extensive involvement or more severe involvement where topicals alone are not going to do the trick. While we've had tremendous improvements in psoriasis management with the development of new biologics, we also now have new oral agents. So oral options may be very helpful for patients, especially those who just are too fearful to even consider a biologic therapy. Lakshi, thank you so much for educating our listeners.
Thank you, Dr. Feldman. It was a pleasure to speak with you today.
Thanks for joining our discussion with our guest, Lakshi Aldredge. There's much more ahead in the coming episodes. In fact, we're going to have Andy Blauvelt next time discussing biologics versus biosimilars. So be sure to check out the Medscape mobile app and share, save, and subscribe if you enjoyed this episode or are looking forward to that next one. I'm Dr. Steve Feldman for Medscape in Discussion.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Stephen R. Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on psoriasis.